All right. I'm Phil Eskew. I'm a family physician, also an attorney, and MBA. La-di-da. That's that. I do some volunteer work with the Primary Care Coalition. I'm the general counsel, and I've been tracking this policy stuff since probably my first year of residency, if not sooner, back in 2012, and been aggregating practices in a DPC mapper across the country. So I was asked to speak about DPC futures from a legal and policy perspective, but you can't talk about the future unless you know the past and the present. So let's start there. When I first put this project together in 2014, I was doing a scholarly rotation at the Robert Graham Center, which is the research arm of AAFP, and I started putting these things up, and they showed me how to put it in mapper format, so there you have it. This was the first rendition of it, 125 different locations I found in 2014. There were probably more than then, I just hadn't found them. Of course, everybody used a different word. More and more people call this DPC, but even back in 2014, there were more adjectives than I know what to do with. Moving on to 2015, we had 290 locations. There should be another heat map on here. I'm not sure why it's not displaying. Hopefully the others will. 2016, we're now up to 445, and you can see some of the red areas are getting even more red. I think, as you'll see, Colorado's winning the award there. They've got more DPC practices than any other state, and then just got bigger. So this is where we are now. We're just above 620. I made a few more updates this week, and there's more and more locations all the time. If you go back and sort of do the math here roughly on the numbers, we go 125, 290, 445, 620. We are growing, but I'd call it linear rather than exponential. So I'm happy with it, but I think it could be better, and I think physicians should be adopting it a little faster. So if you follow that linear progression, maybe make it a little bit exponential. Those would be my sort of conservative preferences of where we could wind up. If we talk about why physicians are adopting this and where it works, you wind up having scope discussions. And I believe in broad scope primary care. So I'm not content as a family physician to just treat diabetes and hypertension. There are a lot more things we can diagnose. We can diagnose myasthenia gravis. We can write the pruritus stimulate ourselves. We can order the CT scan. All those things are possible. And when you do broad scope, you actually provide more value. And I'm fearful that part of the reason we haven't had wider adoption of DPC among family physicians isn't necessarily because of the administrative and legal issues. I think that's an easy cop-out. I think there are too many people that are happy to punch in, sort of go through their day, and not have to work all that hard, and just refer within the system. We need to change that. You tend to see more of this attitude in rural areas, which is nice. I haven't worked in some of the urban areas where you might have some specialty network problems either, but the larger the network, the more pressure there is to make all these referrals to justify all this stuff. And if you look at physician ratios, we've gotten off. Most of the well-functioning health systems around the world have a 50-50 ratio between primary care and specialists. And now we're about 30-70 in favor of specialists. So we have a maldistribution problem that we need to fix, and it won't be easy. So, where were we from a legal perspective? 2006, things were rather bleak. We had one state with DPC law in the books. The first one out there was West Virginia. That was in 2006. This was Vic Wood, who was actually a graduate of my DO school down here in Lewisburg, right there. Started running a DPC practice up in Wheeling and got nasty letters from the insurance commissioner saying you can't do this. And eventually, all by himself, got a law passed, and it was terrible. And what it did was it boxed him in. They said, we're not going to close you down, but we don't want this to grow. We don't want anybody else to do this. And we just don't want your patients calling our office anymore telling us to leave you alone. So, here. What did it do? He couldn't market himself to anybody who wasn't already on a high deductible plan. He had to get approval for his prices from the Certificate of Need Board. There were all kinds of terrible restrictions in there. Fortunately, we've changed that this year, which you'll see later in the slide. Move forward to 2007. Garrison, State of Washington. First green flag to be raised there. And this was critical for a lot of reasons. So it had its own share of problems, but it was a good law, far better than West Virginia's, and it became an example for what wound up as the small DPC provision in the Affordable Care Act. The Affordable Care Act, when it comes to defining what the heck direct primary care actually is, referenced Washington's law. Then we had a gap until 2011, no more action. And then Oregon looked at West Virginia and said, let's do that. And they passed another bad law. They didn't go to their neighbor. They said, let's do this. And so that's troublesome. We still haven't fixed that, as you'll see. 2012, Utah got on board. Utah has another problem, which we'll get into a little bit later, that they don't let you dispense medications, which is a big problem for value adding in DPC. But they did pass a nice DPC law. It was short and sweet. Called it retainer, but you can get over that. And then 2014, we have a lot more action. So Louisiana passed a law modeled after Washington's. Florida started talking, New Hampshire started talking, and Arizona passed a one-paragraph law that basically says, DPC is not an insurance company if it does not take on financial risk. So they didn't solve the problem. That's why I labeled them yellow and irrelevant, because they didn't define anything, and they didn't really remove the risk from the equation. Oops. We haven't fixed that yet either. Move on to 2015, even more action, and mostly on the good side. Arkansas did pass a law, which you'll later see they turned green eventually too. 2016, and now finally, 2017. So if you add all these up, including the greens and the red and yellow, we're at 21 states. That's what happens when you send in a presentation on Monday. Since then, we've had a surprise from the Virginia governor. So Virginia's actually a green state too. I think we're going to have law passed in Florida and Alabama by the end of the year, and maybe Maine. Maine is very early. The other states are kind of harder to predict. The pink ones gave up. There was a question earlier about why is Blue Cross messing this up for us? There's not an easy answer to that. They certainly messed it up in South Carolina and Georgia. And I think they messed it up because they're scared of it and don't understand it. If you look at what the ACA did to insurance company revenues, they're fixed at a certain percentage. So I forget what that percentage is, but let's say it's 10%. And if we shorten their pie, right, assuming they were making 10% on everything, now they have 10% of a smaller number. So at that cursory level, they may therefore be opposed to DPC. Interestingly enough, they didn't raise much objection in a lot of these other states where things sort of sailed through. Wyoming, Nebraska, those laws passed without a single nay vote, and they were signed by the governor. We've had several other states where it's been widely bipartisan as well. So that's the overview. Any questions on that so far? Okay. So state policy prediction, what are we going to do? This kind of goes back and tells you we're at 21 states now, maybe 3 more in addition to that. I wasn't counting Virginia at the time. I think by the end of 2018 we'll have a majority of states. We'll probably be above 25, and at that point you'll be the weird state if you haven't done something on DPC. The policy barriers are going to shift, at least at the state level at that point, because while you might not have it on the books, most states do, and other courts will tend to reference that, so we'll all look a lot better even if you're in a state that doesn't have law yet. So you got to worry about these other issues. So in-office dispensing, Montana, Utah, Texas, New York, New Jersey, Massachusetts, you cannot do that right now. And that's one of the 3 big value adds of DPC. Pathology direct billing laws are a problem in about half of the states, although that's because we don't do nearly as many skin biopsies as we do prescriptions. Okay, so this is a kind of weird prediction. So if I ask people in this room if you're fans of HMOs, I think pretty much everybody would boo, right? But the weird part is you might be able to use this to your favor if you're a large DPC organization in some of the Northeast states. So there are a lot of problems HMOs create, and they have a lot of exceptions written in. If you read the code, there are all kinds of things that they're allowed to do that a routine office wouldn't be allowed to do. So for one, it's not necessarily legal in most states for somebody to open up a business and employ a physician. You have something called the corporate practice of medicine, which means a corporation shouldn't be telling the physician what to do. And all the physicians in the room know that's pretty laughable. We get told what to do all the time. But HMOs, by law, are allowed to tell you exactly what to do. They wrote that in, so that was an exception for them. But there are other exceptions that sort of work in our favor rather than against us. And in New York and New Jersey, that includes things like in-office dispensing and laboratory exceptions. So you can't do direct lab billing in those states, but with an HMO, you have a vehicle to do it. So you may see HMOs offered alongside a PPO or another plan where the HMO is nothing but DPC. It's just in an ironic vehicle. So current questions you're probably going to get at the policy level, whether you're talking to other physicians, whoever. Is DPC the same as concierge? You have to deal with that all the time. And the easiest way to distinguish the two is concierge doesn't have a legal definition. What it is known as is a fee for non-covered services membership plan. So those folks do a lot of double billing. We don't. That's the easiest distinction. Will you file claims for a TPA or broker? These are things that are routinely asked of large employers, and it's something even small DPC practices are going to have to tackle more and more over the years. So the question is, how can you prove yourself, if you choose to do so, without eroding the model you chose to practice in? So what I hate is the term like $0 claiming, ghost claiming. I think we need to avoid those things, but we need to find a way to communicate and prove ourselves to the TPAs at the same time. So there are ways to use software to try and make that process easier. This is another thing employers are going to ask you more and more. Will you work with our patient's current physician? And that's typically a problem because their current physician is in fee-for-service and maybe a specialist who they've labeled as their current physician. So we have to overcome those hurdles. Well, I still use urgent care, similar answer there. I can use this for my HSA, right? Wrong. So we have to go over that hurdle too. With employers, you can have a detailed conversation. You can reference some of the legal stuff that's already out there. One-on-one with your patients, don't get into it. Just tell them to talk to their accountant. Most of the time their accountant will read the code and make a logical conclusion, which is yes, you can. One-on-one, that risk is fairly okay. That risk is fairly low of them being audited or the IRS pursuing that. But larger businesses do need to pay attention to it. And can you guarantee savings? So some of the larger DPC groups that go directly to employers actually do put guarantees in there. And depending on how you structure the data and all the other back-end stuff above, you can really get burned if you're not careful. Future questions, are you a real DPC practice? So each state that passed law provided some sort of definition. The definition was not meant to be exclusatory, but was meant to protect the groups that needed protecting from the insurance commissioner. I've had people ask me, why does why have this definition at all? I do a direct practice where I charge cash pay fee for service. Why can't I be in the DPC mapper, for example? And my response is, I have nothing against your practice, but it's not the legal definition of DPC because the insurance commissioner is not beating down your door. So you didn't need to be defined in this cohort. Do your physician's practice broad scope? I already sort of spilled the beans on that. Are you transparent with all your pricing? That was a good question that we had earlier. Price transparency is a huge component of the DPC movement. You become the vehicle for your patients throughout the rest of the system. It's not good enough to just tell them the price of your practice. You need to be able to tell them the prices of the specialists in town and why Dr. Smith, the surgeon, charges $200 for his colonoscopy and Dr. Burt charges $500. Maybe there's a reason. Let's see. Can you help me avoid or abandon my network? That's a question we might get more and more from employers that are exasperated. Right now they're tied to their networks and they assume there's a lot of value in them. And what happens is as a DPC practice, you wind up building a narrow network from the ground up, but nobody calls it that, right? You built it. You know who's quality, you know where to send people, and your patients aren't complaining because they're actually exposed to price transparency throughout the system. So we actually have narrow networks that make sense, and the top-down ones from the third-party payers never did, and I don't suspect will. Okay, let's see. Referrals, that's another thing I was blogging about recently. So the referral rate over the past 10 years, what do you guys think's happened to the referral rate among family physicians? How much? What's a typical referral rate back in 1990?
20%.
From family doc's office. It was actually close to 5%. Now the data, which is still, you're talking 2010, like 2000 to 2010, I believe was a study that I looked at, it went from about 5 to 10%. So in most hospital-owned practices, I suspect it's even higher. But in DPC, you can push that close to 1 or 2, because you have time to research things. Rather than saying, I don't know, and reflexively referring, you get to look it up, you get to do that stuff. And if you're not willing to do that, DPC is not for you. And that's part of my fear earlier, is that I think we do have a lot of physicians that are perfectly content to never open a book. And they need to change that mentality. And then the other thing I would predict is sort of the collapse of the enemies of price transparency. So one of the biggest ones out there are pharmacy benefit managers. They were put in place to try to supposedly use their size and aggregate other groups and become even bigger and negotiate on behalf of both sides, and those sides being the pharmacy and the pharmaceutical companies that were selling the medication. And instead what they did was they blinded the prices to each side and took the biggest kickback possible. It's just outright fraud if you look at a lot of it, and that's why they've been sued by several different entities to the tune of several $100 million. It hasn't been enough to dissuade them because they've made a lot more. But you can bypass them as a DPC physician. If you're dispensing medications, they can't touch it. If you're prescribing and using GoodRx, they get a much lower chunk than if you went within the system. Large hospital systems do the same thing. They try and use their size to leverage higher prices, not necessarily leverage value. So these are the groups that really, this is who should be opposing DPC legislation at the state level. This is who should be opposing us at the federal level. The PBMs and hospital systems are pretty much blissfully ignorant, and the insurance carriers occasionally raise their hand. So carriers there, I get annoyed when I hear politicians talk about selling insurance across state lines. They haven't used their law degree if they had one when they say that. That's not going to happen. That's at the state level, and it's been litigated at the Supreme Court previously. So, you know, the way to fix that is by incentivizing competition in each state. You're not going to have an aggregate health care plan that way. New regulations. So, size limitations. So this is, if DPC really takes off the way we all expect, what's going to happen down the road? We already sort of have this definition on the books, which I can tell you. The nice thing is, even in some of the bad states, they don't tell you what your scope has to be. They don't come in and say, you must do a colonoscopy or not do a colonoscopy. Whether or not you're brave enough to do that in your office is kind of up to you. Whether or not you bundle that in is up to you. And we're going to see more and more, they're going to come in and tell you what to do. Why? Because if it has favorable tax status, then the IRS has to decide what scope counts. There's some DPC practices that work in massage therapy for a monthly membership. Does that count as part of it? Do certain things have to be cohorted off? So you will have incentives that sort of push you to offer a certain scope at some point. Specialists might be excluded. So right now that's not really the case, but I'm sure everybody in the room can imagine if, let's say we got everybody in here and we had some huge venture capitalist who has like $1 billion who said, I love all these DPC docs, and I happen to live in Southern California, so I want to pay you all a ton of money, and we're going to move everybody to Southern California, and we're all going to live on the beach, and we're going to have this beautiful, massive DPC practice, and we're going to bring in all these specialists, and we're going to do everything you can. What's that sound like?
HMO.
We're Kaiser, right? So at some point, it becomes a problem, and you do have a business of insurance, HMO-ish issue, whether you wanted it or not, if you get big enough. And I think we're going to have some sort of regulation about that. This is probably 10 to 20 years down the road. Data reporting obligations are hopefully going to be standardized in our favor to the extent they do exist. So part of the discussion earlier was, you know, if you're talking with a broker, large employer, they want to count all these widgets, and I don't want to report that data because I know the data's crap. And that might be true, but the answer is not necessarily to report nothing. It's to tell them what should be reported. We know what matters. And when they start trusting us to actually report what matters, then we can re-standardize what actually should be reported and change their apples to oranges. So there's my Twitter handle and my email. If you have any questions, I'm happy to take them now or maybe a little bit later with the panel, Jay.
In a bit. Yep.
Okay.
Thanks, Bill.